Hi, I'm George. I'm a fifth year medical student at Cambridge. I'm studying at Sydney, Sussex.
Hi, I'm Hector. I'm also a fifth year medical student and I'm studying at Clare.
Hi, my name is Lauren. I'm a third year medic at Clare, and this year I'm studying history and philosophy of science.
I'm Adani, and I'm also a fifth year medic at Emmanuel.
Hi, I'm Parvesh. I'm also a fifth year medical student at Emma as well.
And I'm Shiz. I'm another fifth year medical student and I'm at Clare.
Okay, so I'm just going to talk through really briefly about the format of the event and then we can basically crack on. So we're going to start off with a little introduction to the principles of resource allocation, just very generally. It's very entry level, and Hector's going to take us through that with a little presentation. And then we're going to move on to Parvesh, who's going to argue that we did not abandon our ethical compass. And then we're going to go to George, who is going to argue that we did. And then we're going to open up the discussion to the floor. So anyone can comment, anyone can ask a question directed to anyone who's spoken, anyone can reply to the questions if you want to. And we encourage any discussion. And so if when we're going through the presentations, if you do have something that comes up, feel free to just drop it in the chat and write down your questions. If not, when we get to it, you can use the raise hand function and then you can unmute yourselves and we'll have a discussion together. So yeah, and I'll pass to Shiz and he's going to compare the questions. So I think we'll start off with Hector, who's going to take us through a little introduction to the principles.
Great, thanks. I'll get started then. So welcome to our first event, COVID-19 and resource allocation. Did we abandon our ethical compass? And as Lauren mentioned already, I'm going to introduce some general principles of resource allocation to give you all a context for the later talks, which are specifically about COVID. So I'd like to start off by explaining what is meant by ethical principles and what makes a principle of resource allocation ethically significant. An ethically significant principle is one that is in keeping with the principles of distributive justice. What is a principle of distributive justice? Well, this is a principle which underpins distribution of benefits and burdens across a society. And the important thing about this definition is that it recognizes that no matter which principle you use to allocate resources, there will be people who benefit and people who don't. So there are benefits and burdens, and that is true for all principles of resource allocation. I've listed some examples of distributive justice principles here. The first, egalitarianism, that means equality, and it states that because all people are morally equal, they should receive equal material wealth. Desert-based principles reward people for the work they've done, and so they receive what they deserve. Utilitarianism aims to maximize welfare across the society, and in so doing, we can think of it as a principle which gives value to things only if they maximize welfare or happiness. Libertarian principles aim to maximize self-ownership and freedom, and they aim to correct for any limitations to freedom on the basis of people's wealth. And feminist principles aim to compensate for the reduced time that women may spend in the market economy because of childbearing. So it aims to correct for that unfairness. The two main distributive justice principles that apply to healthcare are egalitarianism and utilitarianism. Like I said, egalitarianism aims to distribute equal material goods to all members of society because all members are morally equal. Utilitarianism aims to maximize welfare, and in the context of healthcare, we can think of that as a maximization of good health or a minimization of morbidity. And it's important to recognize that these two principles, although they are the most relevant to the healthcare context, they are actually in tension with one another, and they often result in compromises when it comes to resource allocation decisions. And the rest of my talk really focuses on considering these in more detail and focusing on the differences between them. So I'd like to start off with egalitarianism in a bit more detail. And there's varying degrees of egalitarianism. The purest form, called strict egalitarianism, is very literal in the sense that it focuses on the distribution of material wealth or tangible wealth, and considers this to be the best way to do justice to everybody's moral equality. And this does sound great, but it quickly runs into problems. For example, as I've written below, one of the complications of this when it is applied to real life is the index problem. And the index problem recognizes that different people have different preferences and desires, and therefore to give everyone equal material wealth in the same form might actually result in people being worse off than they would have been if they had the opportunity to choose what they receive. For example, if everyone was to receive 5 apples and 5 oranges, the people who don't like apples would have been better off if they received 10 oranges, and vice versa. And in the context of healthcare, we can apply this analogy because people have differing needs when it comes to the healthcare they need, and therefore to say that every person should receive a fixed amount of healthcare resources, either in the form of money or those resources themselves, is actually going to compromise people. Yes, they may be receiving materially equal packages, but that doesn't mean that everyone will be as well off as they could have been. And therefore, we need to operate through a form of equality of opportunity rather than equality in literal material wealth. And this does seem to happen in our NHS. There is an equality of opportunity to access healthcare services and receive healthcare resources that are proportional to your needs. So in that sense, we are equal. We are equal because we have equal access, not because we will each receive equal funding towards our healthcare needs. And this becomes difficult because you can't quantify access, you can't quantify opportunity. So then we have quite an abstract concept here. And money itself remains the most commonly used metric or index of measurement for equality. And I will highlight how that is the case when I talk a bit more about utilitarianism. But for the time being, we can at least accept that as a concept, there is equality of opportunity within our healthcare system. Another problem or a criticism that might be made about egalitarianism is that by imposing equal wealth on everybody, you might impinge on the freedom of others. And the easiest example I can think of in the context of healthcare is that if you were to illegalize private healthcare so that everyone had equal access, irrespective of their privilege, you would be impinging on the freedom of those who do have the capability to access private healthcare. And this isn't the place to discuss whether private healthcare is ethical or not, but you can start to see how it would be problematic to impose a way of life, let's say, on certain members of the society. So I've introduced a couple of complications or criticisms of egalitarianism, and now I'd like to consider whether or not there's a solution to this. One potential solution is John Rawls' difference principle. And the difference principle states that social and economic inequalities are to be to the greatest benefit of the least advantaged members of society. So in a counterintuitive way, you almost provide equality by creating inequalities that benefit the least privileged. So by creating greater access, let's say, or providing greater wealth or support to the least privileged, you make sure that everybody is on an equal footing. And in doing so, you create equality. And an important feature of the difference principle is that this this benefit that is given to the least advantaged members of society is only valid if you don't impinge on the liberties of others. So it seems to solve what I've mentioned above as problems or criticisms of egalitarianism, and this does occur in real life. For example, in the UK, those of us who are wealthier pay greater tax for the benefits of those of us who are poorer. So by doing that, the liberties of nobody's liberties are impinged upon, but an inequality is created that benefits those who are least advantaged. And that provides everyone with an equal footing, an equal degree of access to healthcare. So before I move on, I'd just like to summarize quickly what I've said. So I showed you some distributive justice principles as ways of endowing ethical significance to the decisions that, say, a government might make to distribute resources. It's clear that no principle is perfect, as every principle will result in burdens and benefits being distributed. The most relevant principles to healthcare are egalitarianism and utilitarianism. And I've gone through some strengths as well as some flaws of egalitarianism, as well as a solution to these problems. However, the criticisms don't stop there, because the proponent of utilitarianism will continue to criticize egalitarianism for not maximizing utility, or in other words, not maximizing the welfare of the population being served. So welfare-based principles or utilitarian principles are very much the argument for maximization of distribution. And a utilitarian approach will state that any decisions made or resources used are only valuable in so much as they increase the welfare of the population. And the word instrumental is often used to describe these decisions or these resources. So they're instrumental or instruments that are used to achieve welfare. So the welfare is the final goal, not the decisions made or the process itself. And what does welfare really mean? Well, I'd like to introduce this man on the right, Jeremy Bentham, who was a philosopher and social reformer of the late 18th and early 19th century, who's considered the father of utilitarianism. And he was very much of the view that the only thing in our experience as human beings that has intrinsic value is our pleasure. And he said that it is the greatest happiness of the greatest number that is the measure of right and wrong. So although at first glance so much talk about pleasure might seem a bit superficial, at least it did to me, there very much is an ethical connotation to this theory. So what is right is what increases happiness, and what is wrong is what reduces happiness. As well as pleasure, welfare can be thought of as happiness or fulfillment or simply having what you want. Now, how does this apply to healthcare? Well, you can consider it as the presence of good health, the absence of ill health, maximized. So as long as the absence of morbidity or the presence of good health are maximized. And utilitarianism is very relevant to our healthcare system in the form of QALYs, so the quality adjusted life year. And NICE will consider whether or not a treatment is cost effective in terms of QALYs per pound sterling. So in terms of the quality of life gained from a treatment per pound sterling. And so cost effectiveness is at the core of our funding decisions and our resource distribution decisions. And considering cost effectiveness as a form of maximization of how far your money gets you, it's very much a utilitarian concept. Now, just like utilitarianism criticizes egalitarianism, egalitarianism has criticisms to return. One of the main ones is that utilitarianism inherently forgets the minority that will suffer from a given funding decision, whereas egalitarianism does not forget them because it makes everybody equal. And a supporter of egalitarianism will criticize utilitarianism because it will make some people suffer for the benefit of everybody else. Another criticism is that utilitarianism tends to treat society as if it's a single human being. So just like all of us can make sacrifices today for our overall happiness in the future, so a minority of suffering for a majority of welfare, so utilitarianism uh, treats society. So you can think of, say, the government as a brain and the population as a body, and the entire society acting as one person. Supposedly, that is how utilitarianism behaves, and it's wrong, says the supporter of egalitarianism, to do this, because you should give credit to the fact that every person in the society is an individual. And finally, there are issues around consent. So with every public health measure, for example, that uses utilitarian principles, there will be those few who are against this, but will not be able to consent for a public health measure being imposed upon them. So the question arises, are egalitarianism and utilitarianism can you ever find a resolution or an adequate compromise between them, or is the tension between them just completely unsolvable? And there are many papers about this, and I would like to finish off my presentation by considering one argument around this topic. So Richard Ashcroft has written about the problem that arises from a perceived impression that this debate is unsolvable. He says that because bioethicists assume that it's unsolvable, they take on a presumption. They take on a presumption of undecidability, and therefore don't even begin to have a rigorous ethical debate in the first place. And by doing this, they make themselves redundant and resort to something called fair process over the distributive justice principles, which I mentioned already. And you can think of fair process as a flow chart which takes you from step to step and guides you in your decision making given certain scenarios. Now, of course, this would definitely be useful in certain contexts, but you can easily see how by replacing a rigorous ethical debate with a fair process, you may come out with a decision that is of a lower ethical quality. And Richard Ashcroft gives the example of the 3x5 initiative, which was the WHO's initiative to treat 3 million HIV sufferers by 2005, who at that time were half of those in clinical need of HIV treatment. And Ashcroft says that there were severe intellectual oversights in the process that led to how the resources for this initiative were going to be distributed. And egalitarianism was used as the guiding principle. For example, it was thought that resources should be distributed equally per person, which meant that many resources were sent to rural areas rather than urban areas. And this does seem great, but then there was a failure to answer the question of quote unquote why the numbers don't count. So why the numbers of lives saved were less important than fairness itself. and there was no attempt to reconcile these two principles. So that's an example of how a presumption of undecidability and therefore aversion towards these debates can lead to a potentially harmful outcome. So in summary, I've shown you how no distributive justice principle is perfect, and one will criticize the other. In healthcare in particular, the most important are egalitarianism and utilitarianism. And we must recognize that these are almost pitted against each other, and that to have a resource allocation principle which satisfies both may be impossible. But this does not mean that we should stand back from the debate, and a bioethicist has a duty to debate and defend the decisions they make. Thank you very much for listening.
Thanks so much for that, Hector. That was really informative, and I hope that everybody learned a lot. I'm basically now going to pass over to Parvesh, who's going to argue that we did not abandon our ethical compass.
Okay, thank you very much, Lauren. I'm just going to share my screen. Can you all see that okay? Cool. So in this talk, I'll give a bit of a brief recap of some of the principles of justice, and then I'll argue for the statement that is shown on the screen. Just to say, the following talks do not necessarily represent our views in total, but we're going to try and convince you each of these views, and we hope they'll encourage some thought and discussion. Okay, so in early March, the UK was launched into an unprecedented pandemic, the like of which we have not seen for decades, and countries across Europe foreshadowed a health service that would not be able to cope with the growing number of cases. And in March, the 9th Imperial Report indicated that services would be overwhelmed, even if the strictest social distancing measures were implemented. And so we were given scientific evidence of an impending disaster, and we were forced to take steps to mitigate that. And from the repurposing of large event venues to hospitals and evidence-based treatment approaches, I'm going to argue that many of the decisions taken had a strong moral and ethical basis. So let me start by introducing some viewpoints of earlier philosophers. Okay, so fair resource allocation can kind of be seen as a balance between the ethical principles of autonomy and beneficence versus justice. And in a society where there is surplus, it'd be easy to give everyone the treatment that they needed, and there'd be much left over for everyone else. In our society, however, we're restricted by money and many other factors such as space and time, and it's up to us to decide what constitutes the just distribution of resources. So to look at the viewpoints of a few philosophers, as Hector mentioned, Bentham takes a utilitarian viewpoint of justice and argues that utility should be maximized. So things should be done efficiently, and the way that resources are allocated should be to the benefit of the whole of society. In contrast, Nozick argues for a free market approach, and maybe some of our neighbors across the pond would deem this to be the fairest. It says that the treatment someone gets should depend on the money that they have. Perhaps the most convincing argument for justice is by John Rawls, who describes a thought experiment called the veil of ignorance. In this, he says, imagine yourself stood behind a veil of ignorance and you do not know your situation on the other side. Perhaps you would be rich and prosperous, or maybe you'd be poor and subject to many diseases. In this situation, how would you want society to treat you? And it's clear that from many people's responses that in that situation, although it's hard to imagine given the way we're brought up, a poor and unwell person would want society to help them to become better. In terms of resource allocation, it basically means that resources should be allocated according to their need. So to talk about COVID-19 specifically, a prominent oncologist and ethicist by the name of Ezekiel Emanuel wrote a paper in May 2020 entitled "The Fair Allocation of Scarce Medical Resources in the Time of COVID-19." And in the paper, he stated 4 fundamental values which were to maximize benefits produced by scarce resources, to treat people equally, to promote and reward instrumental value, and to give priority to the worst off. And he argued that by following these 4 fundamental values, decisions made would be both moral and ethical. And I'll use these as kind of templates to argue the case. So the idea of maximizing benefit of scarce resources is consistent with a utilitarian view of justice. I make the most efficient use of the resources available. But maximizing benefit itself is very difficult to define. Is it the number of lives saved, or is it the number of total life years that are increased across the population? Emmanuel argues that the number of lives saved is the only thing that can be measured and maximized in the short term, and so should be the key factor in determining what decisions are made. At the start of the pandemic, the UK government converted large event venues into hospitals to treat acutely unwell patients. And in hospitals, there was redistribution of beds within wards to help ensure the capacity was available to treat acutely unwell patients. Given the comparable situations in Europe and especially Italy at the time, it was quite a necessary decision to have this capacity. And it does clearly support a utilitarian view of justice in maximizing the number of lives saved. However, I'd argue that it also supports a Rawlsian view of justice. And to make this argument, I'm going to talk about a principle called the rule of rescue. So the rule of rescue is a moral principle that argues that if a life needs saving, it should be saved regardless of the cost involved. And from behind Rawls's veil of ignorance, it would seem both moral and appropriate that if resources allow for it, the capacity should be there to treat these unwell patients at that time. And people in society, many people would agree, and it would be morally reprehensible to not provide this capacity when there are predictions that there'll be so many people unwell and resources present would allow us to do this. Okay, so another point that Emmanuel made was to promote those with instrumental value. So the NHS is run by dedicated and caring healthcare staff. Emmanuel argues that policy should promote and reward those people. From a utilitarian viewpoint, if key health workers are unwell with COVID-19, there won't be people to care for the people in hospitals, and there'll be major difficulties. So in the UK, healthcare workers were given asymptomatic testing to prevent massive spread across hospitals and also to give them peace of mind. In addition to that, the government's Joint Committee on Vaccination and Immunisation have set out guidelines for who should get vaccines at different times, and priority has been given to health and social care workers to be given vaccines earlier than the majority of the population. Another key moral principle is to respond to scientific evidence, and through a utilitarian lens, responding to scientific evidence is likely to lead to the best outcomes and maximize the number of lives saved. It can be seen in approaches such as lockdown, social distancing, and test and trace measures. Another example, evidence has shown that the case fatality rates are the highest in those over 80, and that accounts for 14% of case fatalities. So it seems just and fair that vaccine prioritization guidelines should be based on health risks such as age and other conditions such as diabetes and heart conditions. And that's also part of the guidelines in the UK for vaccine distribution. Another example responding to scientific evidence is response to studies to help determine treatment. So NICE, which is the body for deciding what medications should be used for different diseases, basically responded to the recovery trial And the recovery trial gave evidence that dexamethasone could save lives in severe and critical cases of COVID-19, so people who are on ventilators or people who are on oxygen. In contrast, in America, with the lack of evidence, huge numbers of prescriptions were spent on hydroxychloroquine with no evidence at the time, and later evidence in the recovery trial showed that it actually had no effect. And finally, Emmanuel also argues that you should not place the burden of decision-making on physicians alone, because such difficult decisions could cause a lifelong emotional toll. An example of a life-saving treatment, which is very rare and only present in some hospitals, is called ECMO. And that's a machine that is able to artificially oxygenate blood outside of the patient's body. And it's especially useful in a patient suffering from respiratory failure, which was very common in COVID. And given the limited supply of ECMO machines, it's important to triage them effectively. So in the hospitals which were able to provide ECMO, triage guidelines were developed by the trusts, and MD teams were involved in making the clinical decisions. So this helped to kind of spread the burden of the decision-making in these difficult cases. So I've put forward a number of arguments for why the decisions made were moral. And despite the well-intentioned responses, perhaps our greatest blunder was in some cases acting too little too late. And it's a shame that sometimes poor leadership led to slow and uncoordinated decision-making. It would be impossible to argue that all decisions made were ethical, such as temporarily stopping track and trace, which had no scientific basis. And I'm sure George will provide many arguments for why decisions were unethical. But despite sometimes there being poor implementation, it should not take away from the fact that decisions on resource allocation were appropriate and were often similar to many approaches taken around the globe. So it's important to realize again that no overarching theory of justice can be moral in every situation, as Hector said. However, the approach taken was done in a moral and humane way to benefit those at the greatest acute risk. So thank you very much for listening. I'll hand back over to Lauren.
Thanks so much, Parvesh. That was great. You put forward a really, really strong argument for something that's quite hard to argue for. Now I'm going to pass over to George. And before I do that, I just want to say, if anyone does have any questions or comments that they want to pop in the chat, keep them coming, because just after George, we're going to open up the discussion. But then again, if you want to speak, you can always put your hand up later. So just keep thinking of anything you want to say or bring up. Now I'm going to hand over to George, who's going to argue the other side of the debate.
Thank you, Lauren. Let me share my screen. Okay, so yeah, thank you very much, Hector, for giving us a really good introduction there at the beginning and introducing everyone to some of those key principles that are behind distributive justice. And thank you, Parvesh, also for arguing against this, the argument that I'm going to put forward now. And I think it is actually really important to appreciate that actually there was a huge amount of ethical decision-making that was going on behind the scenes, and it was really in the forefront of the minds of the government officials and politicians and everyone who was involved in this decision-making, albeit with many pitfalls that I'm going to discuss here. So yeah, I'm going to be talking about how we did abandon our ethical compass, and ultimately there was a lot more we could have done over the pandemic. So before getting into some specific examples about what happened during the pandemic, I thought it would be good to set the scene a bit and ask a few questions about who was actually behind the decision-making processes. What was different about the COVID-19 pandemic versus other times, sort of peace times, as it were, and actually why does any of this matter with respect to ethics? So in answer to the first question, I think it's quite apparent that actually politicians really were spearheading the decision-making process. And by default, this meant that resource allocation was inherently influenced by political agendas in this case. And this isn't something we actually saw in COVID-19. This is a phenomenon that exists all across like all forms of resource allocation. And often this can impede the use of scientific evidence and ethical principles to make an informed decision with respect to resource allocation. So that's already a bad sign. It's also true that disasters understandably going to generate lots and lots of ethical dilemmas. And all of this comes down to a dramatic and quite sudden reduction in resource availability. There's often quite huge demand and also reduction in available services to cater to that demand. And this fundamentally changes the way in which we do our ethics and carry out our resource allocation. And it can often lead to moving towards more strong principles of distributive justice, just as a means of finding an ethical solution. The things I'm going to argue as well on top of that is that actually the worst outcome in this case is to pursue a course of action that is not informed by any ethical principles explicitly in any way, shape or form. I think that is obviously a very unethical thing to do. But further to this, Hector very eloquently put that actually there is no one ethical principle for distributive justice that will do everything perfectly and will be fully ethical. But I think that doesn't stop you from critiquing some of the negative outcomes that can arise from following established ethical principles, and that actually, like he talked about this culture of undecidability, we can actually probably move towards something that's a bit better and integrates lots of ideas together. So in terms of talking about different aspects of unfair resource allocation, I'm going to talk about this at several different levels. Firstly is with respect to the disease itself, and then a bit about wider direct health effects. And by that I mean the impact on health services and how this has impacted other diseases that aren't COVID. And also I'm going to talk a bit about wider indirect health effects. And by that I'm really going to be talking about socioeconomic factors that have been affected by the lockdown and various other policies during the pandemic. So with respect to managing the disease, the first part is obviously slowing the spread. So there's, as the Imperial report predicted, this is the graph I put here on the left here, we were facing a quite phenomenal and quite hard to imagine loss of life, really. And what I put on the left here is this graph showing the number of critical care beds which are going to be occupied. And you see this black do nothing line, which soars very, very far above our surge capacity for intensive care beds, which is the red line. This is obviously going to pose many, many ethical dilemmas. And actually, the lockdown ultimately did work in preventing this loss of life to some degree. What I put here on the right is the weekly deaths. Obviously, there was an excess of deaths over the baseline, the yearly baseline. But ultimately, the lockdown did help slow the pandemic and prevent acute loss of life. And this is certainly a morally virtuous thing to do. I think something to note about this is that actually some of the most vulnerable groups, even under this policy, were not protected. So even though I think the fact that it wasn't enacted very well, particularly in the circumstance of care homes where there was tragically a huge loss of life, I think remains to be answered, really. And that's before I get on to talking about treatment. So what I'm going to argue here is that actually treatment escalation options were not distributed justly among our population. And that left various groups basically being unfairly treated by some of the policies we followed. And the first one I'm going to talk about is intensive care. That's obviously got thrown into the limelight as a sort of the top of the treatment escalation ladder for patients with COVID. And intensive care is something that is very resource intensive, obviously, and quite often can fall under the rule of rescue, which Parvesh mentioned, which is that actually any life is worth saving no matter the cost. But obviously, during the coronavirus pandemic, we had limited resources and crucially a massive increase in demand. And this did necessitate triage protocols in order to select the patients who are most likely to succeed and maximise the benefit for everyone, maximise the welfare in a utilitarian fashion. And the end result of this is the use of what were effectively discriminatory exclusion criteria for patients to be eligible for intensive care. So NICE actually used the clinical frailty score, which basically took into account a patient's age, their existing comorbidities, their frailties, and certain disabilities. And basically that dictated the treatment pathway that patients followed when they entered hospital, whether they were ultimately going to be eligible for intensive care or if they were going to be put down an end-of-life care pathway. Now, this is quite a strictly utilitarian approach. It doesn't treat everyone equally, but it's aiming to maximise the welfare and the lives saved. And that is in many ways justifiable, but actually the crucial detail is that ICU care capacity was never exceeded. what I've included here is the same picture from Parvesh's presentation, which shows the Nightingale Hospital basically remaining empty, much like it has done for much of the pandemic. And actually, some of these utilitarian approaches were perhaps put in too soon, and what we got left with was discrimination, really. I've also put on here a bit about DNA CPR forms. There were a lot of concerns over inappropriate use of these over the pandemic, and sort of anecdotal evidence from GP surgeries, instead of doing it on a case-by-case patient, individual patient basis, just sending out DNA CPR forms to everyone, for example, with a long-standing learning disability. And this is obviously very unethical and very bad practice. And this is something that CQC is actually going to put a large investigation into. So that's a bit about managing the disease and some of the issues around that. Now, I think it's going to be pertinent to talk about some of the wider direct health effects. And for this, well, I'm predominantly going to be talking about healthcare services. And obviously, everyone knows that there's been a huge reduction in available services during the coronavirus pandemic. The effects of this are still quite unclear. It involves lots of descriptive and retrospective data, which is probably going to take years to fully crystallize. And our understanding of this is still quite poor. But there are definitely some potential effects that we can draw out at this stage. Firstly, there has been an observed excess non-COVID deaths, and that's what's put on this graph here on the right in the red zone, is more deaths than you would expect from non-COVID causes. There are also an increase in deaths at home. Both of these are likely to be because of patients being unable to access or not wanting to, not feeling empowered to access healthcare services during the lockdown, and ultimately becoming more and more unwell, or a destabilization of sort of long-term chronic health conditions. We've also seen a potential increase in suicide, and whilst this is yet to be established, I think this is something that is very understandably is probably very likely to have happened, because people's mental health is likely to have deteriorated due to the reduction in the availability of services and the unique stresses of the lockdown. And also there's likely to be a huge burden of undiagnosed cancers over this period. And this is something that the deaths that I put on the right are unlikely to pick up until many, many years down the line. So in terms of the ethical basis for this, I think you definitely could justify this as a utilitarian approach. I suppose what you have done is traded the potential loss of life from coronavirus in place of, and that's been favoured over sort of more routine services and other urgent care. And in that respect, you could justify this as a utilitarian way of maximising benefit or minimising the harm and minimising the total deaths over this time. But actually, what I think might be more worrying is the fact that actually there might not have been an ethical basis behind these decision making at all. I think lots of these hospitals were faced with basically quite sudden either shortages of staff or beds or resources more generally. And actually a lot of these decisions were made really, really quite quickly, and hospitals were suddenly unable to operate their A&E departments anymore, or GP surgeries were forced to shut. And actually beyond that, you could even argue that this action was inherently unethical. And that is to do with the rule of, this is to do with the levelling down principle. And this is something that basically says that if you have an inequality, it is inappropriate to remove services from the disadvantaged group in order to bring about inequality. So in this context, it would be patients with long-standing health conditions that have had their services become unavailable. Removing those services just to reach an overall net benefit or a increase in positive outcomes is not something that is actually an ethical thing to do. Finally, I'm going to talk a bit about the socioeconomic factors and some of the detrimental effects that lockdown has had in this respect. And it was designed to protect essential services and slow transmission. And it wasn't a benefit that was distributed equally, but it was a burden, a deprivation of liberty that was distributed equally among all members of our population. However, the effects of this were obviously not felt equally, and there were certain groups in society that were dramatically more disadvantaged by this than others. So jobs, for example, there was a huge amount of job and income insecurity, particularly among low-income workers. Schools obviously provide a huge amount of educational support for a whole generation of children. and it was actually children from poorer backgrounds who had more education. There are also threats of social care cuts, particularly for disabled groups. And there were certain established at-risk groups, such as those who are at risk of domestic violence, which is very sadly something we've seen an increase of over lockdown. And ultimately what this demonstrates is that equality has been chosen in preference over equality of opportunity in here. And actually, the imposition of a lockdown, all it's done is further increase the existing inequalities that we see in our society. So bringing it all together, I'm just going to hammer home that fact that decision making in this context was heavily politicized. I think we live in a time where the political influence in decisions like this is more than ever, really. And this really doesn't do justice to the ethical and scientific bases between making decisions around resource allocation. I've also shown a few examples where decision making was informed by established ethical principles, but did lead to negative outcomes. And I think this is something that is still reprehensible. And decision making, there may have been times where this was done without any ethical consideration whatsoever. And I put here a bit about procedural justice, because actually, as Hector said, that there is no one ethical distributive justice principle that can do all things. And actually, perhaps we should be working towards a more collaborative approach to this, and solving problems like this where inherently there has been a lot of harm done to people in our society. So that's all from me. I've just put up this any questions slide. I don't know if someone wants to introduce and open the floor.
Okay, thank you so much again, George. That was really, really nicely argued. So now we're going to open up the floor.